coronary artery disease, angina, chest pain due to ischemic myocardium, secondary to coronary artery nerving or spasm. Remember, there is no necrosis. Stable, usually secondary to atherosclerosis, equal or greater than 70% occlusion. Exertional chest pain in the classic distribution, resolving with rest or nitroglycine. Unstable, thrombosis with incomplete coronary artery occlusion. Increase in frequency or intensity of chest pain or any chest pain at rest. No cardiac biomarker elevation versus non-ST segment elevation MI, that is N-STEMI. Vasospastic, that is formerly called is transmetal or variant angina, occurs at rest secondary to coronary artery spasm. Transient ischemic ST changes on ECG. Tobacco smoking is a major risk factor. Triggers include cocaine, amphetamines, alcohol, triptans. Treat with calcium channel blockers, nitrates, and smoking cessation if applicable. Angina, chest pain due to ischemic myocardium, secondary to coronary artery nerving or spasm. No necrosis. Stable, usually secondary to atherosclerosis. Equal or greater than 70% occlusion. Exertion chest pain in classic distribution, resolving with rest or nitroglycine. Unstable, thrombosis with incomplete coronary artery occlusion. Increase in frequency or intensity of chest pain or any chest pain at rest. No cardiac biomarker elevation versus non-ST segment elevation MI, that is NSTEMI. Vasospastic, that is transmetal or variant angina, occurs at rest secondary to coronary artery spasm, transient ischemic ST changes on ECG. Tobacco smoking is a major risk factor. Triggers include cocaine, amphetamines, alcohol, triptans. Treat with calcium channel blockers, nitrates, and smoking cessation if applicable. Myocardial infarction, most often due to rupture of coronary artery atherosclerotic plaque that would lead to acute thrombosis, and there will be increased cardiac biomarkers. For example, CKMB and troponins are diagnostic. So we have three types of angina. Uh, okay, that is stable angina, unstable angina, and transmetal or uh, vasospastic angina. So stable angina, unstable angina, NSTEMI, and STEMI. Stable angina, pain on exertion. Unstable angina, mild exertion or at rest, there will be pain. In NSTEMI, there will be pain at rest. It's in STEMI, the pain will be at rest. In stable angina, troponin level, no elevation, while in unstable, again no elevation, while in NSTEMI and STEMI, elevated level of troponin. In stable and unstable angina, there is no infarction, while in case of NSTEMI, there will be subendocardial infarction, while in case of STEMI, there will be transmural infarction. That means all the layers would be involved. ECG changes, possible ST depression and or T-wave inversion. In unstable angina, possible ST depression and or T-wave inversion. So same is stable angina. In NSTEMI, there is ST depression and or T-wave inversion. But in STEMI, there is ST elevation and pathologic key waves. So once again, myocardial infarction most often due to rupture of coronary artery atherosclerotic plaque, acute thrombosis, increased cardiac biomarkers, for example CKMB and troponins are diagnostic. Pain in stable angina and exertion, in unstable mild exertion or at rest. In NSTEMI, pain at rest, and in STEMI at rest. No elevation of troponin in stable and unstable, while elevated levels in unsteamy and steamy. Infarction, there is no infarction in stable and unstable, while there is subendocardial infarction in unsteamy, and there is transmural infarction in steamy. ECG changes, possible ST depression and or T-wave inversion in case of stable, unstable, and unsteamy. But there is ST elevation and pathologic Q waves in case of steamy. And we have ischemic heart diseases manifestations. Coronary steel syndrome, distal to coronary stenosis. Vessels are maximally dilated at baseline. Administration of vasodilators, for example, dipyridamole, regadenoson, or we can say regadenoson, dilates normal vessels. Blood is shunted toward well-perfused areas. Ischemia in myocardium perfused by stenosed vessels. Vasodilator stress tests rely on differential flow to detect potential ischemia. Rarely, they can cause coronary steel and true ischemia. Sudden cardiac death. Unexpected death due to cardiac causes within 1 hour of symptoms onset, most commonly due to lethal arrhythmia, for example, ventricular fibrillation. Associated with coronary artery disease, up to 70% of cases. Cardiomyopathy, for example, hypertrophic and dilated, and hereditary channelopathies, for example, lung QT syndrome, Brugada syndrome, prevent with implantable cardioverter defibrillator. Chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage. Myocardial hibernation, potentially reversible left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Once again, coronary steel syndrome, that is distal to coronary stenosis. Vessels are maximally dilated at baseline. Administration of vasodilators, for example, dipyridamole, regadenoson, dilates normal vessels. Blood is shunted toward well-perfused areas. Ischemia in myocardium perfused by stenosed vessels. Vasodilator stress tests rely on differential flow to detect potential ischemia. Rarely they can cause coronary steel and true ischemia. Sudden cardiac death, unexpected death due to cardiac causes within 1 hour of symptom onset, most commonly due to lethal arrhythmia, for example, ventricular fibrillation associated with coronary artery disease, up to 70% of cases. Cardiomyopathy, hypertrophic indilated, and hereditary channelopathies, for example, lung QT syndrome, Brugada syndrome, prevent with implantable cardioverter defibrillator. Chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage, myocardial hibernation, potentially reversible left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Evolution of myocardial infarction. Commonly occluded coronary arteries, left anterior descending artery greater than right coronary artery, then left circumflex artery. Symptoms would be diaphoresis, nausea, vomiting, severe retrosternal pain, pain in the left arm and or jaw, shortness of breath, and fatigue. Time from 0 to 24 hours. The gross changes would be like we would have occluded artery that would lead to dark mottling, pale with tetrazolium stain. On light microscope, wavy fibers from 0 to 4 hour, early coagulative necrosis. from 4 to 24 hours. Cell content released into blood, edema, hemorrhage, reperfusion injury, free radicals, and increased calcium influx. So there will be hypercontraction of myofibrils that would lead to dark eosinophilic strips, right? These are dark eosinophilic strips. Okay. The complications would be ventricular arrhythmia, heart failure, cardiogenic shock. So there will be baby fibers. From 1 to 3 days, there will be hyperemia, and there will be, on light microscopy, there would be extensive coagulative necrosis. Tissue surrounding infarct shows acute inflammation with neutrophils. The complications would be post-infarction fibrinous pericarditis. From 3 to 14 days, on gross there will be hyperemic border, central yellow-brown softening. In light microscopy, there would be macrophages, then granulation tissue at margins, and the complications would be free wall rupture that would lead to tamponade, papillary muscle rupture that would lead to mitral regurgitation, interventricular septal rupture due to macrophage mediated structural degradation that would lead to left to right shunt, and left ventricular pseudoaneurysm, the risk of rupture. Okay, from 2 weeks to several months. On gross, there will be gray white scar, and on light microscopy, there would be contracted scar complete. The complications would be post cardiac injury syndrome, heart failure, arrhythmias, true ventricular aneurysm, risk of mural thrombosis. Okay, once again, from 0 to 24 hours, that would lead to occluded artery, dark mottling pale with tetrasodium stain, wavy fibers from 0 to 4 hour, early coagulative necrosis, 4 to 24 hour, cell content released into blood, edema, hemorrhage, reperfusion injury, free radicals and increased calcium influx, hypercontraction of myofibrils, dark eosinophilic strips. Complications would be ventricular arrhythmia, heart failure, cardiogenic shock. From 1 to 3 days, there will be hyperemia, extensive coagulative necrosis, acute inflammation with neutrophils. Complications would be post-infarction fibrinous pericarditis. From 3 to 14 days, there would be hyperemic border, central yellow-brown softening, macrophages, then granulation tissue at margins, free wall rupture that would lead to tamponade, papillary muscle rupture that would lead to mitral regurgitation, interventricular septal rupture due to macrophage mediated structural degradation that would lead to left-right shunt, left ventricular pseudoaneurysm, risk of rupture. From 2 weeks to several months, there would be gray-white scar, and contracted scar would be completed. The complications would be post-cardiac injury syndrome, heart failure, arrhythmias, true ventricular aneurysm, risk of mural thrombosis. Okay, diagnosis of myocardial infarction. In the first 6 hours, ECG is the gold standard. Cardiac troponin I rises after 4 hours, peaks at 24 hours, and is increased for 7 to 10 days more specific than other protein markers. CKMB increases after 6 to 12 hours, peaks at 16 to 24 hours, and is predominantly found in the myocardium but can also be released from skeletal muscle, useful in diagnosing reinfarction following acute MI because levels return to normal after 48 hours. ECG changes can include ST elevation, that is ST elevated MI, that would be transmural infarct, ST depression, that is found in end-STEMI, that is subendocardial infarct, hyperacute, that is peak T waves, T wave inversion, pathologic Q waves, or poor R wave progression, evolving or old transmural infarct. So troponin I, it is raised from day 1 till day 7 to day 10, right? While CKMB is not that much raised, right? Okay, once again, in the first 6 hours, ECG is the gold standard. Cardiac troponin I rises after 4 hours, peaks at 24 hours, and is raised or increased for 7 to 10 days, more specific than other protein markers. CKMB increases after 6 to 12 hours, peaks at 16 to 24 hours, and is predominantly found in the myocardium, but can also be released from skeletal muscle, useful in diagnosing reinfarction following acute MI, because levels return to normal after 48 hours. ECG changes can include ST elevation, ST depression, hyperacute peak T waves, T wave inversion, pathologic T waves, or poor R wave propagation that would evolving or old transmural infarct. Okay, this is important. ECG localization of STEMI. Infarct location, and we have leads with ST segment elevations or Q waves. Interoseptal, that is supplied by LAD. The leads through which they could be detected is V1 to V2. Interoapical, that is distal LAD, leads would be V3 to V4. Interolateral, that is left interior descending or left circumflex, that is V5 to V6. Then we have lateral, that is supplied by left or lateral circumflex, that is lead 1 and AVL, and L stands for lateral and left. Inferior, that is supplied by RCA 2-3 AVF. Posterior, that is PDA V7 to V9, and ST depression in V1 to V3 with tall R waves. Once again, interoseptal LAD V1 V2, interoapical distal LAD V3 V4, interolateral LAD or LCX V5 V6, lateral LCX I, that is lead 1 and AVL, inferior RCA V2-3 AVF, posterior PDA V7 to V9, ST depression in V1 to V3 with tall R waves. Okay, now we have narrow complex tachycardias. Narrow QRS complex less than 120 millisecond, rapid ventricular activation via normal ventricular contraction system. Tachycardia originates within or above AV node, that is supraventricular arrhythmia. So the examples are atrial fibrillation, irregular rate in rhythm, no discrete P waves, arrhythmogenic activity usually originates from aromatic foci near pulmonary vein ostia in left atrium. Common risk factors include hypertension and coronary artery disease may predispose to thromboembolic events due to left atrial blood stasis, particularly stroke. The management would be rate and rhythm control, cardioversion. The definitive treatment is ablation of pulmonary vein ostia. Consider anticoagulation based on stroke risk. So here there is irregular baseline and there is absent P waves in atrial fibrillation. Once again, atrial fibrillation, irregular rate in rhythm, no discrete P waves, arrhythmogenic arrhythmogenic activity usually originates from automatic foci near pulmonary vein ostia in left atrium. Common risk factors include hypertension and coronary artery disease may predispose to thromboembolic events due to left atria blood stasis. particularly stroke. Management is rate and rhythm control, cardioversion. Definitive treatment is ablation of pulmonary vein ostia. Consider anticoagulation based on stroke risk. Then we have multifocal atrial tachycardia. Irregularly, irregularly, irregular rate in rhythm. Same just like atrial fibrillation. At least three distinct P-wave morphologies. Multiple ectopic foci in atria associated with underlying conditions such as COPD, pneumonia, and heart failure. So we would have three distinct P-wave morphologies, right? Once again, multifocal atrial tachycardia, irregular rate in rhythm, at least three distinct P-wave morphologies, multiple ectopic foci in atria associated with COPD, pneumonia, and heart failure. Then we have atrial flutter, rapid succession of identical consecutive atrial depolarization waves causing sawtooth appearance of P waves. This is important. Arrhythmogenic activity usually originates from re-entry circuit. This is also important. Around tricuspid annulus and right atrium. Treat like atrial fibrillation plus minus catheter ablation of region between tricuspid annulus and inferior vena cava. So the distance is the same, but there is sawtooth pattern. Once again, atrial flutter, rapid succession of identical consecutive atrial depolarization, sawtooth appearance of P waves, arrhythmogenic activity usually originates from re-entry circuit, tricuspid annulus in the right atrium. Treat like AFib plus minus catheter ablation of region between tricuspid annulus and inferior vena cava. Then we have paroxysmal supraventricular tachycardia, most often due to re-entrant tract between atrium and ventricle, most commonly in AV node, commonly presents with sudden onset palpitations, lightheadedness, diaphoresis. The treatment would be terminate re-entry rhythm by slowing AV node conduction, for example, vagal maneuvers and IV adenosine. Electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of re-entry tract. So there will be only QRS complex that would be formed. Once again, paroxysmal supraventricular tachycardia, most often due to re-entering tract between atria and ventricle, most commonly in AV node, commonly presents with sudden onset palpitations, lightheadedness, diaphoresis. The treatment would be terminate re-entry rhythm by slowing AV node conduction, vagal maneuvers, IV adenosine. Electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of re-entry tract. Okay, then we have Wolff Parkinson White syndrome, WPW syndrome. Most common type of ventricular pre-excitation syndrome, abnormal fast accessory conduction pathway from atria to ventricle through bundle of Kent. Bypasses rate slowing AV node, ventricles partially depolarize earlier, so characteristic delta wave with widened QRS complex and shortened PR interval may result in re-entry circuit, supraventricular tach. The treatment is procainamide, ibutylide, and avoid AV nodal blocking drugs, for example, adenosine, calcium channel blockers, and beta blockers. So we have delta wave and the PR interval is short while the QRS complex is widened. Right? Once again, Wolff Parkinson White syndrome, most common type of ventricular pre-excitation syndrome, abnormal fast accessory conduction pathway from atria to ventricle through bundle of Kent. bypasses rate slowing AV node, ventricles partially depolarize earlier, characteristic delta wave with widened QRS complex and shortened PR interval may result in re-entry circuit that would lead to supraventricular tachycardia. Treatment is procainamide and butylide. Avoid AV nodal blocking drugs, for example, adenosine, calcium channel blockers, and beta blockers. Then we have wide QRS complex tachycardias. Wide QRS complex have greater or equal to 120 millisecond. Slow ventricular activation outside normal ventricular contraction system. Okay, tachycardia originates below AV node, that is ventricular arrhythmia. So we have ventricular tachycardia, typically a regular rhythm, right, is greater than 100, most commonly due to structural heart disease, for example, cardiomyopathy, scarring after myocardial infarction, high risk of sudden cardiac death. Once again, these have wide QRS complex. So ventricular tachycardia, typically regular rhythm, rate greater than 100, most commonly due to structural heart disease, for example, cardiomyopathy, scarring after myocardial infarction, high risk of sudden cardiac death. Then we have torsades de pointes. So here we have polymorphic ventricular tachycardia. Shifting sinusoidal waveforms may progress to ventricular fibrillation. Long QT interval predisposes to torsades de pointes caused by drugs, hypokalemia, hypomagnesemia, and hypocalcemia. Torsades de pointes means twisting of the points. The treatment is defibrillation for unstable patients and magnesium sulfate for stable patients. Drug-induced long QT, A, B, C, D, E, F plus no. A for antiarrhythmics, group 1A and 3, and arsenic. Antibiotics, macrolides and fluoroquinolones. Antipsychotics, that is haloperidol and chloroquine. Antidepressants, TCA, and diuretics, which include thiazides. Antiemetics, ondansetron. Antifungals, fluconazole. Navir, which is a protease inhibitors. Opioids, for example, methadone. Once again, torsade de pointe is polymorphic ventricular tachycardia, shifting sinusoidal waveforms, may progress to ventricular fibrillation. Long QT interval predisposes to torsade de pointe, caused by drugs, hypokalemia, hypomagnesemia, hypocalcemia. Torsade de pointe means twisting of the points. The treatment is defibrillation for unstable patients, magnesium sulfate for stable patients. Drug-induced long QT, A, B, C, D, E, F plus no. Antiarrhythmics, group 1A and 3, arsenic. Antibiotics, macrolides, cefro, fluoroquinolone, right? Antipsychotics, haloperidol, chloroquine, antidepressants, TCAs, diuretics, for example, thiazides. Antiemetics, ondansetron, antifungals, fluconazole, Navir protease inhibitors, opioids, methadone. Then we have ventricular fibrillation, the disorganized rhythm with no identical waves. The treatment is fatal without immediate CPR and defibrillation. So no discernible rhythm. Then we have channelopathies, inherited mutations of cardiac ion channels, abnormal myocardial action potential, increased risk of ventricular tachyarrhythmias, and sudden cardiac death. Brugada syndrome, autosomal dominant, most commonly due to loss of function, mutation of sodium channels, increased prevalence in Asian males, ECG pattern of pseudo right bundle branch block. and the ST segment elevation and lead V1, V2 prevent sudden cardiac death with ICD intracardiac devices. Congenital long QT syndrome, most commonly due to loss and mutations of potassium channels, affects repolarization. We have Romanov-Ward syndrome and Jarvell-Nelson syndrome. Both are autosomal. Romanov-Ward syndrome that is dominant, but Jarvell and Lang-Nielsen syndrome that is recessive. So Romanov-Ward syndrome, autosomal dominant, pure cardiac phenotype with no deafness. Jarvell and Lang-Nielsen syndrome, autosomal recessive with sensorineuronal deafness. Then we have sick sinus syndrome, that is age-related degeneration of SA node. ECG can show bradycardia, sinus pauses, sinus arrest, junctional escape beats. Once again, ventricular fibrillation, disorganized rhythm with no identifiable waves. Treatment is fatal without immediate CPR and defibrillation. No discernible rhythm. Hereditary channelopathies, we have two types: Brugada syndrome, congenital long QT syndrome. So in Brugada syndrome, we have autosomal dominant, most commonly due to loss of function mutation of sodium channel, increased prevalence in Asian males, pseudo-right bundle branch block, ST segment elevation, and lead V1, V2, prevent sudden cardiac death with intracardiac devices. Congenital long QT syndrome, most commonly due to loss of function of mutation of potassium channels, affects repolarization. Romanov-Ward syndrome, autosomal dominant, pure cardiac phenotype with no deafness. Jarvell and Lang-Nielsen syndrome, autosomal recessive, sensory, sensory neuronal deafness. Sick sinus syndrome, age-related degeneration of SA node. ECG can show bradycardia, sinus pauses, sinus arrest, and junctional escape beats. So here we cannot see a P wave. Sometime it is missed, right? Okay. Then we will start from conduction blocks.